Hello everyone. My name is Femina Patel. I am PGY1 Internal Medicine resident at the University of California, Riverside. Today I'll be talking about the rare case of primary anorectal submucosal melanoma. It is a rare disease that may arise anywhere along the mucosal lining and has a very poor prognosis. Most patients are commonly misdiagnosed with hemorrhoids, benign polyps, or other type of rectal cancer. Now, due to its varied anatomic location as well as presentation, our current understanding of the disease is limited, with no evidence-based guideline for its management. Here we present a case of 81-year-old unfortunate Hispanic male with a medical history of hypertension, type 2 diabetes, and recent cataract surgery presented to the ER with the sudden onset of inability to urinate for the past 2 days. He had dizziness, lightheadedness, and slowed speech noted earlier that day. His CT head without contrast was negative for acute event. Patient was diagnosed with obstructive uropathy with acute kidney injury managed by nephrology on floor. The following day, he developed new onset right arm weakness. His MRI brain showed a recent small infarct in the left cerebrum. His angiogram showed complete occlusion of the left MCA-M1 territory. Bubble study was negative for intraarterial shunting, and patient was stable and there was no indication for stenting or intervention during that admission, so he was discharged on aspirin and clopidogrel for 2 months and outpatient follow-up with urology and neurology. 2 weeks later, he presented with black maroon color stool in the ER. CT abdomen pelvis without contrast showed soft tissue rectal mass. He underwent EGD which showed gastric polyp and arteriovenous malformation treated with prophylactic organ plasma coagulation. His colonoscopy showed tubular adenoma type polyp in the ascending and transverse colon and a 2 cm oozing ulcerative mass at the anorectal region. Biopsy results came back positive for a submucosal invasive melanoma with spindle cell type feature with the melanin pigment. However, no neoplastic changes were present in the overlying squamous epithelium. His immunohistochemistry stains were positive for S100, HMB45, and MART1. Patient was eventually discharged to the nursing home facility with outpatient follow-up with surgery and oncology for staging, prognosis, and treatment option evaluation. Now to recap a little bit, our patient had biopsy-proven primary anorectal submucosal melanoma, presented as a stroke, secondary to the hypercoagulable state of malignancy. Anorectum is the third most common location for melanoma, after skin and retina. Yet, only 0.4 to 1.6% of all primary melanomas arises here. There is no clear evidence or guideline for optimal surgical management. The choices ranges from abdominoperineal resection to the wide local excision with or without adjuvant radiotherapy. However, studies have shown that local disease control has no benefit on survival prognosis. Almost all patients will develop metastasis during the course of the disease and has a poor prognosis with the median survival of 24 months and a 5-year survival of 10%. Here, takeaway home points are: it's a rare disorder with a greater incidence in female. However, the screening efforts undertaken for colorectal cancer may help to detect this disease earlier and need awareness among the clinicians about its existence to avoid delay in the diagnosis. Now, due to rarity of its entity, treatment options are not well studied and have remained controversial. Prospective clinical trials are needed to understand the effective therapeutic approach for its management. That, my friend, is a primary anorectal submucosal melanoma in a nutshell. But we still don't know what are the risk factors or what causes the melanoma in the first place. We need more clinical research to understand the etiology and the risk factors responsible for causing submucosal melanoma. That way, this knowledge will help us to establish screening guidelines for prevention and early detection in such high-risk individuals. Thank you all for listening, and I would like to thank my colleague as well as mentor for their hard work. If you feel free to reach out if you have any questions at my first name Femina.my last name Patel @ucr.edu. Thank you. Have a wonderful rest of your day.